All right, let's talk about something we're all seeing more of in the clinic: the asymptomatic patient with primary hyperparathyroidism. Today, we're going to walk through a really solid framework for how to evaluate these patients, drawing straight from the latest guidance from the 5th International Workshop. So let's just jump right in. The thing is, the whole clinical picture of PHPT has, well, it's shifted. It's not the disease we learned about in our textbooks anymore. Its presentation has evolved, and that means our approach has to evolve right along with it. I mean, for ages, right, the diagnosis was all about that classic triad: bones, stones, and abdominal groans. But now, with routine lab work being so common, especially here in North America and Western Europe, we're just not seeing that florid symptomatic picture as the first sign. It's become way more subtle.
And that really gets to the heart of the matter, doesn't it? It's the core question we're tackling today. You get that lab report back, it's an incidental finding, and your patient is sitting in front of you saying they feel totally fine. So what do you do next? What are you even looking for? This shift from a symptomatic disease to an asymptomatic one is a huge challenge for us clinically.
Okay, so before we can really dig into a framework for evaluation, we've got to make sure we're all speaking the same language. Let's get super clear on the different biochemical phenotypes you're going to see.
So first up, the classic definition. This is your bread and butter hypercalcemic PHPT. It's pretty straightforward, right? You've got an elevated serum calcium, corrected for albumin, and a PTH that's either high or, and this is the key part, inappropriately normal. You know, it's in the normal range, but in the face of high calcium, it absolutely shouldn't be. But here's where it gets a little more nuanced. We have to be really careful to distinguish that classic picture from normal calcemic PHPT, or NPHPT. Now, with NPHPT, you've got persistently normal calcium levels, and that means both your adjusted total and your ionized calcium, but the PTH is high. The two big takeaways here are: one, you have to confirm this on at least 2 separate occasions, and 2, you've got to do your homework and rule out all the other secondary causes first.
Okay, so now that we've defined our terms, what's the game plan? How do we actually approach these patients in a systematic way, no matter which phenotype they have? Let's walk through the recommended framework for a really solid workup.
You know, the modern evaluation goes way beyond just slapping a label on the diagnosis. Think of it more like a detective investigation. It's a systematic 5-part process, and the whole point is to uncover any silent damage the disease might be causing. If you approach it like that, it's much harder for important details to fall through the cracks.
Right, so here they are, the 5 pillars of the workup. We're going to walk through each one of these step by step to see exactly what we're looking for and, more importantly, why it matters for that final decision. First things first, the labs. This is your bedrock. You've got to get that concurrent adjusted total serum calcium, or ionized if you can, along with an intact PTH. That's what confirms the diagnosis. But here's the kicker. You absolutely have to measure 25-hydroxy vitamin D. You need to rule out secondary hyperparathyroidism from vitamin D deficiency, which is an incredibly common curveball. All right, next up, we look at the skeleton, because let's be real, PHPT can be a silent thief, just quietly eating away at bone. The guidelines are super specific here. You need a 3-site DXA. That means lumbar spine, hip, and, this is crucial, the distal 1/3 radius, because it's packed with the cortical bone that PHPT loves to target. Then you have to go hunting for those hidden vertebral fractures, either with a VFA or a spine X-ray. Finding a fracture changes everything. It's a clear green light for surgery.
Pillar number 3 is the kidneys, and we're looking for trouble in 3 key ways. First, you check the eGFR for overall function. A dip below 60 milliliters per minute is a major red flag. Then, you're running a 24-hour urine to screen for hypercalciuria. And finally, you get some imaging, usually an ultrasound, to hunt for any silent kidney stones or calcification.
Okay, number 4. This one's about those non-classic symptoms, the ones that can really affect a patient's day-to-day life. We should be asking about things like brain fog, mood changes, and just their general quality of life. But, and this is super important, notice what's not recommended for a routine evaluation: bone turnover markers. For now, they just don't have a place in making that initial call on surgery.
And our final point is genetics. Now, this is not for every patient. You have to be really selective here. The guidelines tell us to zero in on very specific groups: patients who are younger than 40, anyone who seems to have multi-gland disease, or if there's a family history that smells like a syndrome, like MEN1 or FHH.
Here is to find the hidden damage that PHPT can cause. For our asymptomatic patient, this is really the core of the evaluation. It's about finding what you can't see on the surface.
So first, what are we even looking for? Where are our targets? Even if your patient says they feel great, that extra PTH can be working behind the scenes on a bunch of different systems. So we need to be screening for potential neurobehavioral stuff, checking for kidney issues like stones, assessing the bones for any loss, and keeping an eye out for potential cardiovascular effects.
And this chart, this is why I love pathophysiology. It perfectly illustrates why we're screening for all these things. It connects all the dots for us, from how PTH works to the clinical problems it can cause. You can clearly see how that excess PTH makes the kidneys hold on to more calcium and cranks up bone turnover, and that leads directly to the hypercalcemia, the fracture risk, and the kidney stones that we're trying to find. And focus specifically on that normal calcemic phenotype. When you suspect NPHPT, the evaluation has to be even more careful, even more meticulous.
The diagnostic pathway for NPHPT is really rigorous, and you can't skip any steps. So, step 1, you have to confirm that high PTH on at least 2 separate occasions, maybe 6 months apart. Step 2, you've got to confirm that the calcium is truly normal, both the adjusted total and the ionized. Step 3, and this is so critical, you have to systematically rule out every single secondary cause. We're talking vitamin D deficiency, kidney problems, diuretic use, the whole list. It's only after you've checked all those boxes that you move on to step 4, looking for that end organ involvement with the same exact bone and kidney tests we just talked about.
And here's a really important clinical pearl to keep in your back pocket when you're evaluating these patients. Unlike what you often see in the hypercalcemic folks, patients with NPHPT don't usually have high calcium in their urine. But, and this is a big but, that does not mean they're in the clear. Not at all. They can still have some pretty significant damage to their bones or their kidneys, which is exactly why doing that full comprehensive evaluation is so crucial.
So, we've gathered all this data, the labs, the imaging. What's the point of it all? What's the ultimate goal here? Let's boil this whole process down to its most essential principles.
Really, it all comes down to this. Number 1, nail down the diagnosis using those strict definitions we talked about. Number 2, your main job is to go on a hunt for any silent end organ damage. That's the top priority in a patient without symptoms. Number 3, and this is a big one, remember, imaging like a cystomebi scan or an ultrasound is not for making the diagnosis. It's for the surgeon to help them plan after the decision to operate is already made. And finally, number 4, always be on guard to separate out primary from secondary causes, especially when you're dealing with that tricky normal calcemic picture.
And all of this leaves us with a pretty provocative question, one that really captures the central challenge of modern PHPT. When so many of our patients have no symptoms at all, are we dealing with a disease that we need to actively uncover, or is it sometimes just a biochemical quirk that we can simply monitor? I think the answer to that question is found in doing the kind of thorough, systematic evaluation that we just walked through.